Good afternoon, and welcome to this public briefing of the Standing Committee on Social Development. My name is Jane Wayellen Armstrong. I am the MLA for MUFI and chair of this Standing Committee. At this time, I will ask the members in attendance today to introduce themselves, starting with either one of you.
Good afternoon. I'm Shauna Morgan, MLA for Yellowknife North.
Good afternoon, Julian Morse, MLA for Frame Lake and Yellowknife.
And those online?
Good afternoon. I'm Cheryl Yakalai. I'm the member for the Det'anchogh.
And I'm Kieran Testart. I am the member for Range Lake here in Yellowknife. Well, not here because I am in Inuvik for the Arctic Development Expo. Sorry, I can't be there in person.
Today, committee will hear from the Minister of Health and Social Services about the primary and community healthcare reform framework. At this time, I would like to turn the floor over to the Minister of Health and Social Services. Please proceed with your presentation.
Thank you, Madam Chair. First of all, I'd like to thank committee for having me here today. If I may, I'll just have my staff introduce themselves because I always seem to mess up their titles, and so I'll start with my Deputy Minister and we'll go this way.
Alan Duty, Deputy Minister of Health and Social Services.
Nina Larson, Director, Community, Culture and Innovation. I'm a member of the Gwich'in Nation in Swedish.
Kirsten Berg, Assistant Deputy Minister for Corporate Services and Cultural Safety. Thank you.
Great. And myself, Lisa Semler, MLA for Inuvik Twin Lakes and Minister of Health and Social Services. So I'll just start by a few small opening comments, and then I will turn it over back to you, Madam Chair, for the presentation with, I believe Nina will be doing that. The framework that was circulated, to everybody and that was tabled in the House delivers on our mandate commitment to ensure equitable, sustainable access to primary care in all Northwest Territories communities. Primary and community healthcare services include first contact care, community-based and preventative services, team-based models of care, navigation and continuity supports, and strong linkage to social and community supports. The framework is organized around a vision, the North Star, and 3 constellations that describe what primary and community care looks like in practice. Indigenous cultures and governance at the center, interconnected and relationship-based models of care, and learning systems that use Indigenous knowledge, lived experience, and clinical evidence to drive continuous improvement. The department will focus on key system enablers, including governance, accountability, workforce stability, and sustainability, funding alignment, data, and digital infrastructure. The framework sets a shared, territory-wide direction for regional and community co-design, time-limited, action planning, performance measurement, and future policy and legislative work. Thank you, Madam Chair.
Please proceed.
Thank you, Madam Chair. As the Minister just shared, the definition for comprehensive primary and community healthcare, I would like to add that primary healthcare is more than accessing a physician or receiving treatment. At its core, relationships are the mechanism through which care becomes healing by creating trust and belonging. Every transformation effort needs a shared destination, and the purpose of this framework is to establish a shared territory-wide direction for how care is designed, governed, delivered, and evaluated. Importantly, this direction was developed in collaboration with Indigenous governments through the Northwest Territories Council of Leaders, who endorsed the primary healthcare framework. And as we shared, the North Star is simple. Indigenous people experience physical, mental, emotional, and spiritual well-being. This is not a rigid roadmap, and the Council of Leaders will continue to use the Health and Social Services Working Group to co-design a guidance document that will support the implementation of this framework and to meet the unique needs of each region. We need to begin with from a clear reality. Indigenous people in the Northwest Territories continue to experience significant inequities in health outcome and care experiences. The evidence shows that differences are not explained by individual choices. These disparities reflect structural conditions that shape access to resources and access to services and opportunities for health. This is why training alone is not enough. This framework will focus on structural change through co-design, policy development, implementation planning, and funding and investment decision. Western medicine remains essential, but if there are ways of healing, ways to build relationships and design care that improves outcomes, and we exclude these new ways of doing, then we miss opportunities to better serve Indigenous people. Most importantly, when we improve care for those experiencing the greatest inequities, we strengthen the system for all residents. Transforming this system will require more than new ideas. It requires creating opportunities for leaders to experience different ways of relating and working together. And over this winter, we had an opportunity to offer an experiential learning through the following North Star Summit that was co-hosted with the Council of Leaders Health and Social Services Working Group. And this was an opportunity created to learn together and improve the framework by critically assessing it. But this framework offers an important shift as well. The GNWG continues to have responsibility for organizing and delivering primary care services. Indigenous governments hold jurisdiction over traditional healing and authority over Indigenous cultures that are essential to health transformation and improved health outcomes. This framework intentionally braids Indigenous and Western ways of knowing to transform care, and implementation will look at moving beyond collaboration. It will focus on co-design, implementation, and evaluating care with, for, and by Indigenous people. This framework draws from multiple forms of evidence. We completed 3 rapid reviews, which are a robust mapping process that looks at a specific topic area, looks at peer review and gray literature, and it is also looking at practical ways to apply this knowledge. So the 3 scoping reviews, the first one focused on identifying the core components, structures, and enabling conditions of Indigenous-led or Indigenous-centered team-based care models. The second one focused on equity-based patient attachments, which look at how people get connected and stay connected to a primary care team. The third compared Indigenous and Western frameworks for defining and measuring health system qualities. The findings from these 3 reviews were not treated as separate, but were layered, but the evidence was layered and braided together with what Indigenous communities and residents across the NWT have shared through engagement and evaluation. So we conducted an evaluation from the demonstration sites in Fort Smith, Yellowknife, and Fort Good Hope. We also incorporated learning from study tours, the community wellness plans, youth engagement, and geo-engagement, and a review of 28 reports. In many places, the evidence affirmed and gave additional grounding to what communities have long been asking for and helped shape the language and direction of this framework. Based on the evidence, the framework was organized around 3 interconnected constellations to organize transformation. So the first one is Indigenous cultures at the center. So this really looks at who guides and shape care. interconnected care model, how care is organized and delivered, and the last one, learning communities, how we learn, improve, and stay accountable. To develop the framework, we also used a system mapping approach to understand how different parts of the system interact to produce outcomes. This system mapping helped us move beyond primary health care and examine the broader conditions that shape access to care. And achieving the vision and direction outlined in the framework requires a set of system enablers that support the three constellations. So we facilitated 21 design workshops with nearly 200 staff, and the 4 enablers are governance and decision-making structures, workforce stability and well-being, funding alignment, data and digital infrastructure. And these are the 4 conditions that will make change sustainable. So the first constellation advances Indigenous governance, partnership, and shared decision-making with Indigenous knowledges, languages, and land at the center of care. It recognizes that Indigenous cultures are fundamental to healing and influence how Indigenous people experience wellness. Overall, the findings suggest that when Indigenous cultures are at the center, transformation is reflected not only in how care is experienced, but in how the system will function over time. We have 4 goals for this constellation. The first one is care is guided by Indigenous governance, knowledge system, and cultural authority. Number 2, people experience informed choice, meaningful shared decision-making, and access to their health information and care. Number 3, care reflects a strong orientation towards prevention, community wellness, and the determinants of Indigenous people's health. And finally, cultural safety is reflected in how success is assessed alongside clinical and system measures. The second constellation describes care organized around continuity and coordinated pathway, supporting team-based approaches that bring together Indigenous and Western practices to strengthen access. Overall, the findings suggest that interconnected care is achieved not through adding services alone, but by redesigning care around relationships, community strength, continuity, and the conditions that enable people and teams to thrive. There are 5 goals for this constellation. Number 1, care is organized through team-based approaches that reflect Indigenous community needs, priorities, and contexts. Number 2, interdisciplinary care teams operate clear, collaborative roles and responsibilities, supporting continuity and coordinated care. Number 3, the system supports Indigenous participation, retention, advancement, and leadership across the health workforce. And finally, cultural safety and humility and well-being are embedded in everyday practice to support staff. The last constellation is learning communities, and this looks at advancing decision-making informed by multiple forms of evidence and supported by strong data systems. Overall, the findings suggest that learning communities are created when systems move beyond collecting information to building trust where knowledge informs action, accountability, and continuous improvement. There are 4 goals under this constellation. The first one is decision-making is informed by sustained Indigenous and public engagement with clear feedback and accountability from residents. Care systems, policies, and resource decisions support intergenerational healing and cultural safety. Number 3, continuous learning and quality improvement are embedded across the primary and community healthcare system. And finally, data and digital infrastructure support integrated care, learning, accountability, and Indigenous data sovereignty. Overall, this framework establishes a shared direction while allowing communities and regions to move at their own pace based on local context and health and wellness priorities. This framework will guide regional and community co-design of team-based care models that will be shaped by Indigenous governments, staff, communities, and partners, and grounded in local priority and readiness. It will also guide the development of time-limited action plans, guidelines documents to support evidence-based decision-making and processes, design of measurement frameworks to support accountability and learning, and policy and legislation framework. Merci.
Thank you. Minister?
Yeah, so just to end the presentation, I just have a couple of, and I want to make sure that all residents of the Northwest Territories are clear that, when the focus that we've seen in this framework is more than half of our population is Indigenous people, and when we look at the data that we currently hold, there's no mistaking that Indigenous people in the territories are higher in many different areas, like needs in primary care and preventative care and chronic disease management, many of those areas. So the focus under this, however, this is why we cannot create a cookie cutter primary care for what works in the capital, may not work in the regions, and may not work, in the small communities. So this approach takes the lead from the community. So what will happen in Yellowknife, we have primary care teams. We are looking to expand into different areas and looking in areas like an Indigenous primary care clinic to service, Indigenous people in a different way. However, we're always going to be, it's not going to change our primary care system. It's only going to improve. And the work that we're continuing to do currently especially in the Yellowknife primary care, that work will continue to evolve based on, the work the MLAs are bringing forward, the work that the residents are bringing forward, and the work that's currently being analyzed in that clinic. So it's more of a high-level framework to be able to give the permission to the authority that we have to work in every community a little bit different so that that primary care will be trusted and accessible. Thank you, Madam Chair.
Okay. Thank you. Now I'd like to turn to the committee members if they have any questions. We'll start with MLA Morgan.
Thank you, Madam Chair, and thank you so much for taking the time to be here today. My first question, on slide 7, you talked about the different reviews that you did in the preparation to create this framework, and there was reference to equity-based patient attachment. I wonder if you can explain what that means and what the review was that you did. Thank you, Madam Chair.
Minister?
Yeah, I'll turn that over to Nina.
Okay. Ms. Lawson?
Thank you, Madam Chair. So the attachment refers to a stable therapeutic relationship between a patient and a primary care provider. So through our review, we look at different consideration, so patient complexity, so people with chronic disease, social needs in multiple conditions that may require more time, the provider type, whether it's a physician, nurse practitioner, physician assistants, who have different scopes and workloads. We also look at the team composition, clinic infrastructure, and non-visit work. Overall, what we found is that there's no single size, and so we'll have to test the guidelines to identify the best approach for these guidelines. But overall, we know that panels serving higher complexity population may require smaller number attached to a team, and that size should be adjusted based on complexity. And team-based care allows for panels to be larger only when non-physician roles and coordination capacity are in place. And looking at rural and remote settings, the panel sizes are often smaller due to travel, access, and non-visit work. But really, the composition really depends on the population and the needs of clients.
MLA Morgan?
Okay, thank you, Madam Chair. Thanks for explaining that. So the framework clearly lays out the vision of what we want to see for better health, a more holistic system of care. Can you explain how this might translate into what difference people will see on the ground, say in smaller communities? I mean, that example you gave of doing research and finding that, you might need to have smaller size panels if people's healthcare needs and complexity is higher. So how will this translate into, like, what difference will it make for someone in Gamete or Det'anchogh, or what will they see that will be different as a result of this work? Thank you, Madam Chair.
Minister?
Currently, and I'll highlight some of the positions that they're current, like Indigenous wellness workers are now slowly being recruited, and because in some of our communities, the Indigenous wellness worker might be the most stable relationship that that's local. And so that will be your open door in that community to build that trust. And so that's hearing from residents. And so that doesn't necessarily mean they're going to be the practitioner that's going to assess them, but many people fear that first initial coming into the door. So having a trusted person that's stable, that's always there, even though if they say the nurse is locum. But I'll turn it over to Nina to kind of go more into what the analysis and everything that she did, that her department did.
Okay, thank you. Ms. Lawson?
Thank you, Madam Chair. What it means in practice is that all three constellations need to be applied at the same time to improve care. So it's not about adding more services, but it's really about designing services in a different way through co-design with Indigenous governments, but also supporting teams so that they can work to their full scopes. They have the training available to work together as a team, and they're able to apply cultural humility and to support their well-being, but also to better support Indigenous clients, and looking at data to continuously improve over time.
Okay, thank you. Now we'll go to MLA Morse. You have a question?
Sure. Did you ask two already? Oh, man. Things are moving quick. Okay. Yeah, my first question is maybe a bit similar to the one that was just asked, but I was wanting to understand, I guess, the overarching reforms happening towards the goal of reforming primary care, because I see what was presented today as an aspect of what's going on, but I also get the impression and have seen changes being made well outside of what's mentioned in today's presentation. So what I'm getting at is people's access to care through, the team-based care models that have been implemented in Yellowknife, and whether or not those teams have adequate span of control over a certain number of patients, and just the various things we've been talking about. I know there's been changes to the lab, so there's this discussion that we're having today, and then there's other reforms to primary care that I see happening. And so can you help us understand where we might be able to see, like, the overarching systemic change that's going on that isn't described within this framework? Or is the idea to capture everything under this framework? And I have further, more detailed questions after that. Thanks.
Minister?
So I'll start a little bit, and then I can turn it over to Nina to kind of fill it. And I guess, and I this is the conversation that I had, because I said, whoever we're sitting in front of asking the questions are going to relate they want to understand what it means in their community. So if we go back before we started team-based care, we had physician-based care, and we had physician clinics who were their own, they managed their own clinics. They were that was their business. And now with this day and age, we know that many of those physicians, we've switched over. They now work as employee under the health authority, and they, you know, there's so many positions that are now in the operating budget for certain areas. And when you talk to people in the past, they say, well, I knew my doctor, I knew this, I knew that. But when we look at the physicians that are currently in the system, they're not working like they used to, 7 days a week, on call, 24/7. There's gone. And we shouldn't expect physicians to be working at that. And so what we're trying to manage now is when we look at primary care, we have a set number of doctors that positions in the operating budget that are supposed to be for primary care, but they also do they're hospitalists, they're specialists, they do other things within our system. But we still need to manage that data to say within the team, and I think this is what Nina's saying, is we need to gather that data. If 4 teams are correct, and these are the complements of this team because of the amount of chronic disease and, of other things that are on their team. Do we need an additional team? Is there more chronic diseases in this community where we need more, support for this community? Because we hear in small communities that diabetes is huge. How do we support that community more? Putting the right provider, putting that right. And so I think when I respond to Yellowknife perspective, we know that there's issues with attachment. And I think we spoke about the guiding document on attaching clients. So we know how to attach clients, all of the people we've committed to attaching clients before the end of the year. But does that mean that it overburdens those teams? We need to make sure that it's not. And if it's not, we'll have the data and the evidence to now go, okay, I need to, as a minister, go to get money, because every time you do more things in health, you need more money. So I have to go and I have to get some more money to be able to create a new team so I can have. And so what we're doing here is looking at everything. And I think right now, currently, I've directed the NTHSSA, and they have a team that is analyzing, and over the next 6 months, they're working in Yellowknife primary care, because we know that there's access issues, so, people having a hard time to get to see into their team. We don't want them using the emergency. We don't want them always having to fill up there is needs for walk-in clinic, but we should be able to, have, and there's certain things, and may not be staffing. It may be a computer, maybe the phone, it may be, and so they're analyzing all that like we did with the Det'anchogh journey, so that they'll come back with the recommendations that need to be implemented, so we can hear from the staff, we can hear from patients, and then we can correct those things. But I can turn it over to Nina if she has more to add in the overall of how this allows for that.
Ms. Larson?
Thank you, Madam Chair. I can definitely give an example as to what the framework could look like when applied to Yellowknife region specifically. Overall, the framework gives us the orientation, what we're hoping to achieve, and how our work needs to be guided by that evidence and direction. In Yellowknife in particular, the reform efforts focuses on completing the process for assigning all residents to a fully functional team and to develop consistent practitioner coverage for various programs. And there's 5 areas of focus, and you'll notice how they can be found in different aspects of the framework, in different constellations. So the first one is really looking at mapping episodes of care to identify barriers so that we can improve health outcomes. So going through the journey of clients, depending on their needs. So that looks at UTI patient journey mapping, or diabetes, clients with diabetes, to improve those pathways. The second focus is looking at equity and complexity-based attachment. And this really looks at applying a model to assign residents to care teams especially for clients who have a difficulty being assigned to a team because of complexity and high vulnerability. The third focus is supporting team collaboration and in relationship. And so creating an environment within the organization to have improved communication, building relationship between disciplines, and enabling staff to work to full scope within that team setting. And the fourth focus looks at optimizing roles and scope. So having clear pathways towards preventative care and chronic disease management. And the fifth focus is locum orientation, onboarding, and utilization. So looking at strengthening those to better support a team-based approach. So all those elements, you can find them in different goals of the framework, and when they're applied directly with frontline staff, it really helps us work towards one vision to improving equitable access to care.
Thank you. MLA Morris, do you have a follow-up question?
Yep, thank you. Yeah, and I think you started to touch a bit on my next question, which is, I'm wanting to get into the details more. I guess like what I've seen of the framework so far, it's quite high level, and so I'm curious about how you're planning to measure and show success of implementation of this framework. So I guess getting into the nuts and bolts of what can people actually expect to see change. Is it going to mean, people have ready access to midwifery services alongside prenatal care when they go to any health center or hospital? Is it going to, what are, I guess, the measurables? And what are we measuring to determine success of implementation of this framework? Are there certain outcomes we're looking to change? Are there measurable signs of access improving for people or primary care improving for people? How are we going to measure that success so that we, because it's, I don't think I need to emphasize to you guys that it's a very complex system. And it can be a little bit hard to determine what success is going to look like. So I'm curious to hear from you this is very similar to the question that Emily Morgan asked. What are people going to see change, and how are they going to experience change in the system as this moves forward? Thanks.
Minister?
Thank you, Madam Chair. One of the things that I would say is that, I think right now what we're seeing is the challenge of access and getting on the team, and that would be the first measurable, I think, is once we have people on a team. But over and this is where health, we'll see outcomes, they'll come later. It's like when you start to do the preventative, we want to start to see the data that we're seeing less people with chronic diseases, and we'll start to see those numbers, improving. And that's what primary care is if you have good access to primary care and the information at the level and at the of how you receive information. So it might look different for a small Indigenous community like Colville Lake of how they receive information and how they'll feel comfortable. It'll be different and so we have to be able to adapt to that in the system. We will be providing primary care for those clinical things, but that, as we know, many people, and it's not just Indigenous people, but I think Indigenous people more so are able to elaborate that, but it's that continuuming, it's that holistic approach, whereas having an elder, having somebody, being part of that team, being able to assist that. So when we're saying these types of things, those are the measurables that we're going to see is the improvement of access and the improvement of when we start to the data sets where we're seeing improvement of chronic disease management. Because right now, and I'm going to say from my own career of being in health, we've been managing chronic disease differently in every region. We need to, and that's why in this last budget we've approved a position, and the department is now working on a bigger like, and that's where some of these guidelines will come into place as chronic disease management territorial wide, and how we're going to do that would fit in to this, because we need to be able to do that, and everybody needs to know what we're doing and not piecemeal. So if there's anything more, I can turn it over to Nina if that's, oh God, Ms. Larson.
Ms. Larson? Ms. Larson, yes, go ahead.
Thank you, Madam Chair. One of the things that we have done in the past is, and to this day, is co-design the system together with staff at the front line, and collaborate on this framework with Indigenous governments. But we're really shifting towards co-design, which means that how we measure success will have to be co-designed with Indigenous governments, including in Yellowknife. There are measurements available nationally when it comes to quality, trust, and access. We'll have those measurements as part of a framework that will hold us accountable. But most importantly, the change through this framework will include, as we see in Constellation 1, goal number 4, is that cultural safety be reflected in how success is assessed alongside clinical and system measures. And the Canadian Institute for Health Information just released cultural safety indicators. And so together with Indigenous governments, we'll be able to co-design a measurement framework to identify if we're making progress towards quality, access, and trust, not just from a Western lens, but also through Indigenous quality measures.
Thank you. We'll go to MLA Yakalaya. Please go ahead.
Good afternoon. Thank you for the presentation. And I'm glad the minister mentioned this when she was speaking to the team there and asking them, people want to know, what does it look like in the community? So I want to know what it's going to look like for Fort Providence and Kakisa. What is this healthcare reform going to look like? And also mention teams. What is the teams and what does that look like for the communities? Thank you.
Minister?
Thank you, Madam Chair. So when you look at right now in the communities more, historically have been acting like team-based care, because our base of our health centers are nurses, and then they get support from the staff that work within the facility, so they all work as a team. And usually there are physicians and nurse practitioners, over the years, and nurse practitioners have been implemented to support communities. Physicians have been dedicated to certain communities. And so they have had a sense of team-based care over the years. It's just trying to put it more on paper to say, how is that supporting that community, and what are those needs? So when you look at Fort Providence, Kakisa, for instance, Kakisa's needs, and how do we support that health cabin, and where, and what is their needs, and is it the referral pathways and the supports that are needing to be put into place for somewhere like that versus Fort Providence, and I think that need is going to come from the community themselves. And that's the work that will happen. We will have the guidelines, but NTHSSA will have to work directly with those communities to create what the needs are. And so if there's an increase of this chronic disease there, if there's an increase of mental health and addictions, how does that fit in a cultural lens in an Indigenous community, right? So is it more collaboration with the Indigenous governments in providing care? And we're seeing this more, is that we're working in collaboration with Indigenous governments, and they want to take the jurisdiction of some parts of it, so counseling or things like that. That could be a model that would be emphasized, like that would be allowed under this kind of work. So I'm not sure if Ms. Larson has anything more to add on that, but that would be how we would be able to implement that.
Okay, Ms. Larson? No? Okay. MLA Akalaya, do you have another question?
Yes, also you mentioned improved communication and collaboration. What does that look like for the communities? I bring that up because I had I mean, I can give a little story about how an elder talked to me about how he went for a visit to Edmonton, and they found something on him in one of his lungs, and then the doctor phoned him back, and he doesn't understand what the doctor's saying to him. So the doctor asked if somebody in the house was able to talk to him so he could give the elder the information, and he said no. There was nobody there, so the elder asked the doctor to give the information to the nurse, so the nurse could kind of explain to him, because his first language is an indigenous language. Now, if you're going to improve communication and collaboration, then we need um, medical translators in the health centers that are there to support the people, that the language, to support them with the language so they understand fully exactly what is going on with them, and to understand it, and then to be able to ask questions and to inquire about what is actually happening to them, and what are some options they have that for healthcare. Thank you.
Thank you. Ms. Larson?
Thank you, Madam Chair. Thank you for this question. Looking at the small communities and working collaboratively with the local Indigenous governments will be essential, because their unique needs and priorities, like you've just mentioned. One of the ways that we're able to identify those unique needs is through the journey mapping, by traveling with clients to understand their journey and improve how the healthcare system has been designed. So we have a better understanding of how navigation takes place and what changes need to take place. But that work can't happen without working closely on implementation of the framework with Indigenous governments through the Council of Leaders.
Okay. Thank you. MLA Testart, do you have a question?
Yes, thank you, Madam Chair. So I wanted to start off by saying I have profound respect for the work of Ms. Larson and the department on this work. It is a very difficult issue to confront with any real success. There's been many cultural safety plans in the past, and the issues persist. So I do agree that systemic change is required. However, looking at this framework, this to me reads a very academic document. And I think all the findings are valid. All the findings are, the thrust of it is good as well. But again, this is something I would expect coming from a university or a think tank, to provide governments with principles for reform, not a practical strategy for our own healthcare system. The document also notes that this is not an action plan. This is, sorry, let me get the exact wording, but I'm sure the witnesses understand where I'm coming from here, but it stresses very specifically, this is not an action plan. This is not, shouldn't be taken as an action plan. It should be taken as something that can be measured and to have results and impacts. So again, with so many needs in the healthcare system, I'm sure this thing took a lot of hours and resources to produce. So you've committed that actions will fall out of this and start to see the changes you're envisioning in this framework. So when will those happen? Will they happen within the life of this government? When will we know the costing of those? The minister also said any new actions we take have to be paid for and will require new appropriations. And the document as well contemplates doing so, that new actions will have to be additional, not within existing resources. So when are we actually going to see what this results in? Because what I'm hearing from constituents, and not just my own, but from across the territory, what I'm hearing from frontline workers is they need to start seeing changes sooner than later. And they were saying that 2 years ago. And now we have precious little time in this assembly. So what are we looking at for actual measurable outcomes that are going to realize what's being spoken about in this framework? Thank you.
Thank you. Over to the minister.
Thank you. So when we're looking at the framework, yes, it is a high-level document. And as I mentioned earlier, the actions will come from this, and those are co-developed and co-designed with the health working group, as they are the representatives from the GNWT and the Indigenous governments from each of the regions. And so that work will take place, and I know that's kind of what Ms. Larson has said, is the work that's going to happen with those, then we will implement, and they may not be perfect, but we're going to be listening to those recommendations, whereas before they didn't fit into health and social services over the years. And one of the things that we've also heard from healthcare workers is that they're not feeling that they're able to help their clients and their residents and their patients in the primary care, is because the system doesn't allow for it. This framework is, the way that we want to be able to change how the work is being done, so they're able to feel like they're accomplishing things at the end of the day, and servicing and referring and pulling in other team members into the team to support a holistic care for patients and clients is the main tool for this. And so I think yes, everything I said, well, every time there's a change, and so like when we did the Det'anchogh journey, there's always going to be internal change, and then we analyze it, and then if there's external, like if there's costs over and above, those costs, we'll be bringing forward through our processes. That's the same thing that's going on in Yellowknife Primary Care right now, as we did the patient journey in the Det'anchogh. That same team is now analyzing everything within Yellowknife Primary Care, and they'll come back, and if there's money that's going to be needed to do the things that it's going to make it work for the residents in Yellowknife, then that we will bring through the business process cycle. And I think when we look at for Indigenous patients, and we're looking at different ways to fund an Indigenous primary care clinic so that it takes the pressure off, but it may provide a different perspective. As we've traveled throughout, the team has traveled and visited many different Indigenous primary care clinics throughout Canada, and they work differently. They work differently than our system, but they may not work for everybody. So we need to make sure that our Indigenous population, which is a large chunk of population in the capital, that are going to be serviced in a way that meets their needs. And so there is things happening within the life of this government, and in the lab, we knew that was a big challenge. And most recently, we've have the additional of all of the nurse practitioners that have been approved now, that we will be slowly implementing into these team-based cares. There's a big chunk for Yellowknife, that primary care, and then in the small communities to support small communities and regional centers. So these pieces are happening as we analyze each area. They're not going to all happen at once, but the system is continuing to evolve. And those things that are brought forward as issues, and if there's a financial need, we will bring forward through our business processes to have the money to be able to implement. Thank you, Madam Chair.
Okay. MLA, to start, do you have a follow-up question?
Yes, thank you, Madam Chair. So again, I think I'm not sure what the purpose of this is then, other than to set a high-level kind of principle statement on what the aspirations of the system ought to be, because without and I get that individual actions are going to be how these things are ultimately measured, and how the health system gets impacted, but we need a comprehensive plan to deliver those changes in a measurable and affordable and sustainable way that bring about the changes in a reliable way, so we can show constituents exactly the results that all this work is taking care. And like the lab example is a perfect example. The lab has been putting forced growth submissions forward to the authority for years before this was finally done. So the idea that we need a framework to inculcate those kind of changes, I think is not, I don't get it. I think you can just talk to the staff and say what they need and make the changes. Anyway, I want to get to another point, but those objections still stand. I want to see some, and the people I represent want to see how we're actually going to make these changes. And if it takes 10 years, then make a 10-year plan. But what I'm also concerned about is, and I've heard this from the minister before, Madam Chair, that there's this kind of divide in healthcare between small community and Yellowknife, and the system is very much divided between what happens at Stanton and in Yellowknife and what happens everywhere else. And I think that that's obviously the case when you're dealing with one area with more resources over another, with more doctors, with more nurses, with more staff to offer clinic hours and things like that, and of course the presence of a sophisticated modern hospital. But that being said, the largest Indigenous population out in the Northwest Territories is in Yellowknife. And that comes from all over. So if we're going to, I'm just confused why I keep hearing this kind of what works in Yellowknife isn't what works elsewhere. We need to make sure that there's all this investments in the Indigenous model of primary care that's going to take place outside of the capital, when we have certainly the majority, or if in terms of a settlement population, the largest in Yellowknife. So are we building a model of care that is for everyone, that is going to apply across the system, or are we building two models of care, one in Yellowknife and one everywhere else? Thank you.
Thank you, Minister.
Thank you, Madam Chair. I just want to make sure that I'm being very clear, so that there's no, I believe that, yes, this framework is a high-level document, and that's what frameworks are. They're there to guide the work that needs to happen. And so it has to start somewhere. And as somebody who's looked at all of the documents, as Nina has, there's been many frameworks, there's been many things, but it never started. The work never started. We've done little bits and pieces here and there, but in overall, when we look at the data, the current data that we currently have, it is Indigenous people. And I agree with the member that we do have a large population that has a high needs, and that's why they come to the capital. And we need to make sure that our primary care system for the Northwest Territories, whether you're Indigenous or non-Indigenous, or you're a newcomer to Canada, that you can see a primary care practitioner. But what we do know is that we as a government, are committed to ensuring that for reconciliation purposes, that we need to build that trust back with our Indigenous people in the territory, because we have broken that over centuries of trying to provide services to Indigenous people that doesn't fit. And so here we are, we have people in the Northwest Territories with the highest chronic diseases are Indigenous people. And so we are not building a two-tier system outside Yellowknife, inside Yellowknife. What we're looking at is making sure that we have services outside of Yellowknife and services inside of Yellowknife, all of Yellowknife, for residents. Indigenous residents may need a different type of care initially to build that trust. Eventually, and this is what I said to my colleagues when we were visiting the Indigenous primary care teams, everybody would want to be in that Indigenous primary care team, but we need to start somewhere, and we don't have that currently. We need to have an Indigenous primary care team so that we can see how it's working and how we're adapting and how we're serving Indigenous people. And is the data showing that we're improving? As the other member has said, we need to show data that we're improving. And is this the model that we want to use for the whole territory? We don't know that until we could actually start a clinic and look at it, maybe expand to the regional centers and then to the smaller communities as to how that's going to look. We have to start somewhere, and as the minister, I want it started in this government, and that's what we're doing. Thank you.
Thank you. I do have a question too as well. Okay, in your report, it says that, this work has been led by the Community, Culture, and Innovation Division of the Department of Health and Social Services. So it says with Indigenous government. And with that in mind, I just want to ask you, so what does your consultation look like on this with the Indigenous government, like your view? Because if they were involved, because I don't see anything in this report. The work was done, in collaborations with the Indigenous government. So I would like to know. Thank you.
Thank
Minister.
you. Thank you. So with all of the, I believe with all of the work that was done historically, I think it began with the Indigenous Advisory Body. And then once I was the minister sitting on the Council of Leaders, there were so many things that were coming to us for access care, mental health and addictions, chronic disease, all of those things from Indigenous governments that we created the health working group, which is the executives go away, come up with the work on behalf of their Indigenous governments, and there's representatives from most of the Indigenous leaders, and within the department, they'll reach out to, those that are not at the table. And so that's the work that's been happening to be able to do this. And if I look at some of the different Indigenous groups, there's more participation from some groups based on their, and this has always been in the back of my mind, and this is something that I've always said too, is that we have some more established Indigenous groups that have land claims and have self-governments that have more staff that are capable of doing this work. However, we have to make sure that we're continuously reaching out to those that are not, that do not have the supports in place, that we are still getting their perspective. And so that's what Nina's team and them are doing through the work that they do with this. And so bringing them together, like through the different workshops that they've had, they bring in residents from all across the Northwest Territories. I can, if you want, I can even have Nina elaborate more, but that is the consultation that has been happening. Okay.
Yeah, the reason why I ask is because, so it's not the Indigenous government, it's the Indigenous government organizations that were involved. Because, when this was happening, I did consult it with one of our local chief. And because, we used to have two hospitals, one in Det'anchogh and one in Edzo Cottage Hospital. And I know there was some conversations about bringing back a mini hospital, like to improve the healthcare system. And I know this is, I'm really glad, that the focus here, improving the primary healthcare in small communities. And that's been, we've been asking about that for a long time. And even we did a motion in the 19th to improve the healthcare in small communities, because I think even now, a lot of people are, they're getting tired of visiting the health center and being prescribed Tylenol. And we're trying to get away from that. So that's why I did ask, so if it was just the Indigenous government, if it was the Indigenous government, I know there would have been more, they would consult more. I think there would be more collaborations of what they want in their communities or in their regions. But I think you were working with the organizations, the Indigenous government organizations. So that's how I see the report as. It's not more from the Indigenous government, but from the Indigenous organizations. So, and here, it's also the report, with the methodology, a total of 28 GNWT Health HSSS engagement and evaluation reports were reviewed to ensure framework reflects, that's what you said in your report, and, what Indigenous communities have already shared about their priorities. And a lot of them, I think even we said it, the MLAs have said it, and many of the community members have said it, we need more program and services delivered in small communities. Even I advocated and wanted to see if, medical radiation technologist positions or that equipment can be in some of the regions where possible, even in Klucho community, Det'anchogh, and so other communities can come there. I know there's a long wait list in Yellowknife, so even things like that would help diagnose whatever illness it is, instead of, I know this team-based approach is good, but if we had, this kind of services available, it would help improve the healthcare reform in small communities, because here, so based on that, I mean, but we don't have that. So I don't see it in the report of what, some of the things that can help improve the health system in small communities. And I know having some of these would improve the small community situation, or help improve the healthcare system in small communities. So with that in mind, I just wanted to ask, how many physicians are hired or working in the small communities or in the regions? Do we have any physicians in small communities or working in the regions? Thank you.
Thank you, Madam Chair. I know I asked Kirsten to pull some of that data together. I know that most of the physicians are based in the regional centers and the capital, and they do travel and they do virtual clinics. But in the smaller communities, those are health centers. So those are nurse leads, so registered nurses or nurse practitioner-led facilities. And then we have the health cabins that are serviced by community health workers. And we're looking at right now, we've just implemented the model of the nurse practitioner design to service the Det'anchogh health cabins. And so this is where is one another little piece when you say these are the things that we heard from the community and the leaders and the problems that they were having of access to care, and being able to try and be more responsive and allowing for NTHSSA to change some of the ways that they're providing care, which is different than being a cookie cutter across the territory. And so I think that's one of the areas, but I can give it to Kirsten and she can tell you how many physicians each region has. That's the O&M, but then even with that, they do other things, and so they're not fully dedicated physicians to, so in Inuvik, you have a primary care clinic physician, but they also do obstetrics and emergency. So, and then they service the communities as well. So,
Thank you. Ms. Berg?
Thanks so much. So right now, for staff physicians, we have physicians located in Inuvik and Yellowknife. And then we have both locums and staff physicians traveling to other communities. And to build on what the minister was saying, so we do, our funding model has physicians in the hubs, and so we have, it ranges, but, somewhere between 2 to 7 physician-like full-time equivalents in the hubs. But we're actually using staff doctors and locums from Yellowknife and Inuvik that travel into the communities right now, because we don't have physicians that are located there permanently.
Okay, thank you. Okay, we still have time for a second set of questions, so I'll go to MLA Morgan.
Thank you, Madam Chair. So many questions that are coming out of this conversation, but one is, I think the minister mentioned earlier the idea of an Indigenous primary care clinic in Yellowknife. And so this is also an idea that I've heard bubbling up from various frontline practitioners as well. And I do think it's a interesting idea and a good one, given that, we know that, the largest number of Indigenous people in the territory are in one place or are located in Yellowknife, though they may be from different nations and communities. And as has been mentioned several times before, we know that the inequities or the health outcomes facing Indigenous people are significantly lower than the rest of the population. So something is not working about the ways that people are currently accessing the system, including Indigenous people in Yellowknife. And so if there's a way to create a clinic specifically that changes the approach, that does improve that, I would certainly be all for it. I wondered if you could elaborate on, are there plans underway for an Indigenous primary care clinic in Yellowknife, or at what stage is this discussion at? Thank you, Madam Chair.
Thank you. Minister?
Thank you, Madam Chair. So right now, because of the framework, and I think this is, it's early, but as I told my team, I want this plan finalized, or at least finalized, and, you know, if we have to go through the business process for extra, you know, or to find ways, and I think there's ways that we can, you know, try to access funds through the multiple different options. And I know Indigenous governments have also brought up through this newest assessment, like when we work with the federal government, there's the health assessment that's been going on in the Northwest Territories. Because of all of the D&D that's gonna, you know, with everything that's going on, we're looking at ways that we have a plan so we can start to try and leverage some of these funds, because we do know that, and I always say is, we don't know who's normally traveling, as you mentioned, that Indigenous people are very, they're like caribou, they like to migrate, you know, analogy, like, I've been back and forth to Yellowknife many times. Jane, she comes to me, or Miss Ellen Armstrong comes to me with her constituents that they're back and forth. They live here, they live, you know, and there's no boundaries, but not necessarily are we people to stand up and sign up for a team. So we need to make sure that if we do have a primary care team, that it's not going to exclude people that don't know the process of coming to Yellowknife. And I think that's what the challenge is with Indigenous people in Yellowknife right now, is they have the two options is wait for a same-day appointment if they're not familiar to getting on a team, because in the regions there is no team, there's one team. Like in Inuvik, there's one team. So you phone the clinic and you get an appointment. Right? There's not, am I on this team or am I on this team? There's only one team. And so that's different from it. So we need to make sure that those aren't barriers for Indigenous people to access because they're not and registered. However, once we have them in the system, then they're part of the system, right? And they know where they can go, and then we can try to service their needs holistically in that model. So we are in the infancy, but I want this to go fast, and my team knows that. And I think with this, it's my comment is how are we at Northwest Territories and more than half of our population is Indigenous, and we don't even have one Indigenous primary care clinic, whereas you go to every province and the bigger centers, they have these, right? And they're very holistic. Like you go into the one in Ottawa, they have a smudge room because that's their culture. You go into the one in Vancouver, and the same. They meet the needs. They have a sweat lodge outside in the backyard of their primary care clinic. You know, so we need to know what, you know, we're not going to be able to have every single piece figured out right away, but we need to make sure that the higher level pieces, so people could trust to come into this primary care clinic, is going to be met. And as it grows, you know, maybe it grows to be like, and that's why I said with my staff, they're like, I want to sign up for that clinic. And I think everybody would want to sign up for that clinic. And I think our non-Indigenous and our new immigrants are going to be like, I want to sign up for that clinic. And that could be the future of our model of primary care, right? But it has to start somewhere. And it's starting with these little pieces that we've heard from the residents.
It's one. So, hi. We're doing only one question because we're pressed for time. So I'll go to MLA Yakalaya. Do you have a question?
Yes, I do. Thank you. Yeah, there's so much. There's a lot to this. So, you know, just giving the information to people on the ground about what this is going to look like in our communities and for the people. You know, at the end of the day, people just want to know how is this going to impact them. what does it look like for them in the communities, and how are they going to access it? Like, for instance, I have people that go to the health center in my communities, and they are given Tylenol. They describe a pain, they describe a situation they're in, and then sometimes they're given Tylenol, like my colleague Miss Way Allen talked about, and we want to get away from that. So people go home with the Tylenol or ibuprofen or whatever it is they give them, and then they come back in more a dire situation, and then are sent, and then they find out they have stage 3 or 4 cancer. So I need to know is how can the minister provide examples of how cultural and community-based roles will be brought into team-based care? Um, Given that information I just provided, thank you.
Thank you. Okay, Ms. Lawson?
Thank you, Madam Chair. We had lengthy discussions with the Northwest Territories Council of Leaders Health and Social Services Working Group about this, because Indigenous governments have jurisdictions over traditional healing, as well as other cultural elements of care. And so the ask of Indigenous governments through the Council of Leaders was that we be respectful of that jurisdiction, and that we work together in collaboration to identify place-based, like at the community level, the solutions required. The second issues that we've identified with this is that traditional healers are at times older and elders, and so how do you support the passing of knowledge to the younger generation? But overall, the inclusion of traditional healing within a team will have to be done together with Indigenous governments. It cannot be done by the GNW team.
Okay, thank you, Minister.
Just really quick, and just to relate to Cheryl's comment, it's more of the communication. We need to have better communication, especially in our smaller communities, as to why the first line of medications that are allowed to be dispensed are certain things, and then if those don't work within the first, that's why they always say if it's not helping within the first 10 to 12 hours. But however, we want to be more afraid to come in because they feel like they're not going to be heard. We need patients to feel like they're going to be heard, so we have to make sure that we change the way we're communicating.
Thank you. MLA Tester, do you have a question?
Yes, thank you, Madam Chair. Well, I think first off, if the results improve, then patients will tend to trust the system better. I think that's a big part of it. But I do have a question around the kind of intentions of this. So the minister has said over the course of this briefing that both previous governments committed to doing this work and didn't do it. So if she could elaborate on why this was not done in the past, that's one piece of this. And then the other thing the minister said was that she wants this work to go fast. So how will she make it go fast? Because without action plans, without deliverables, timelines, measurables, resourcing, saying I want it to go fast is all well and good. We all want things to go fast, but there's no guarantee that they will go fast. So if she can give us an understanding of why this work has failed in the past, and if it's a matter of political will, then some honesty would be good about that. If it's a more practical administrative burden, then that's important as well, so we can understand how to alleviate that. And then going forward, if the minister is serious about moving this work forward quickly, then we need to see some actual numbers, because otherwise this is, again, a very important and I think significant piece of conceptual framework for the NWT healthcare system, but it's not going to achieve any results that are going to impact our residents in the near term. Thank you.
Thank you. Minister?
Yes, thank you, Madam Chair. So in the past, like as I mentioned, that there has been many reports done, and I can't speak to, I wasn't in those governments as to why and what the priority was, but I know that coming into this government and being in the government before, putting forward, there were decisions made and things weren't funded. As you mentioned, Lab has been put forward many, many times. And, you know, with the pressures of all the other departments, sometimes there are certain things that get approved and sometimes there aren't certain things. The very first thing that when I became minister, we know that this has been historic obstetrics in the capital. The staffing model that changed from the old Stanton into the new, into a bigger footprint, had the same staffing complement, and we seen that when nurses were leaving their positions, and we ended up sending everybody in the territory pretty much to Edmonton to deliver. So we were able to make sure that there was an extra line of LPNs put into Stanton and funded when I first got in. So those are some of the things that when I say that certain things haven't been implemented and recommendations, sometimes they're not getting the funding. We've got reports, I've said it in the House, you know, we've had seniors, we've had the supportive living plan, but those all take significant amount, millions and millions and millions of dollars to implement. And they're not gonna all get implemented. One report is probably, like, you know, could be hundreds of millions of dollars of spending. One government is not going to be able to allocate all of that unless you don't allocate anything to anything else. And I feel like that sometimes, so what we're trying to do is we're trying to triage and prioritize the things that are going to make the most impact. And then when I talk about moving fast, I didn't say this whole framework is going to be implemented fast. What I said is we need to have the plan established and hopefully with funding before the end of this term for the Indigenous primary care model, and that work right now to establish a team to lead that is currently working in place, or is going to be in place shortly. Thank you, Madam Chair.
Thank you. MLA Morse, do you have a question?
Yep. I guess I'll just say, I mean, at this point, my connection to this initiative has mostly been through these kinds of briefings. So far, this briefing has not given me a lot of confidence in the initiative's ability to succeed. And I would suggest that for me, something that I would need to see at a minimum is a set of current data and metrics that the department would publish and be clear about what we're targeting for improvement. So, for example, you know, just showing what current health outcomes are and what we're hoping to achieve. It's been mentioned as a part of the presentation, but it's not mentioned in the framework itself. And so the difficulty for me is that if we are not showing people what we're looking to change, communicating what we're measuring to determine whether that change is occurring, it's going to be very hard for people to understand what's happening, I guess. So I think, you know, a few MLAs have spoken to this, but I'm really hoping that we can get into actual tangibles as quickly as possible. So we can, get an idea and maybe have the ability to, I mean, at this level, look at it and see if it compares to what we've been hearing from our constituents about what they want to see change. And I wish we had some more time. I had some more questions I wanted to dig into about how we might get to that place. But I guess that's the question I would put on the table is, are we planning to communicate in a clear way exactly what we're trying to change? So an example I would give of that is, you know, here's the current set of health outcomes for chronic disease in the Northwest Territories. We are hoping to reduce that by 30% by 2035, for example. Like, that would be a measurable that we are looking to achieve. That's something that's tangible, I can understand, and I can halfway through that time, let's say in 2031, could look at it and say, we're not even halfway there. So what are we going to change to make sure that we do get there? I realize we're getting very much into specifics, but I think if we don't, the worry is that, you know, I think I saw I think it was the briefing given to us, not the presentation, but that this initiative was first identified as a priority 10 years ago. And that's a long period of time, one in which I would hope that we could have shifted outcomes. So what I don't want to see is that we get this on the table, get working on it, and 10 years from now are having the same conversation yet again about a bunch of high-level kind of thoughts that we have about how the system should change, but we're not actually working on the deliverables. Thanks.
Minister? I know you have to leave
Yeah,
at
no,
3, but
I can answer the question, though. So I just want to make sure that, to be able to respond to this is, I agree, and I think this is the pieces that have come into place. So when you look at tangibles, we should see less medical travel because the plan is working, because we're listening to the community, because we're providing services closer to home. So we should have that tangible measurement that we start to see when, with being able to increase, and I think there's increase staffing, increase medical, technology into the smaller communities, that will help. When I said we are currently doing different things all over the territories when we amalgamated, we didn't have a clear guideline on how we're going to manage chronic disease management. So going to the comment that you made, we have that approved now in the budget to hire somebody to actually come up with that plan with those measurables. And that should be released, I think, by, once we hire, then they have to do the analysis, because everybody, as I mentioned before, every region was governed by their own governing council, and they were doing things different in every region. So now we're trying to do a territorial-wide, how are we going to measure the whole territory? And that's going to take, and I think we have it rolling out within the next 2 years. But all of these things take time, because these pieces, because once we amalgamated, it took, we've only been NTHSSA for 10 years, yes, but everybody's been doing something different, and we're still running a health system. So we're still having to provide services every day, plus we're trying to figure out what each region was doing differently, and then trying to tackle every single little area, which is enormous, right? And so we're doing some things better than we were at the beginning, and some things haven't even been touched. And so that's the measurables that we can provide the things that we, in writing to the members, that we currently, and under primary care, that we will be providing with the data sets, so that we want to be measuring, and that every community should be measuring, and how they're going to be measuring those. However, this work, like I said, yes, maybe it started 10 years ago, and we had a vision that we were going to train everybody. And as I came in, I met with the team, and it was like, well, just by giving a 2-day orientation is not going to solve our Indigenous people's trust in the system. We need to do more. We need to do it differently. We need to actually take these steps farther. And so that's what the team has been doing, is looking at ways that how do we move the things that we need to move steps farther. And is it going to happen all today? No, because we didn't get here overnight, as I always said. It's going to take time to build that trust, and it's going to take time to make sure we're code drafting it and listening to our Indigenous populations and listening to all the residents, because whether it's Indigenous people or non-Indigenous people or newcomers to Canada, they all expect to have services. So we need to make sure that we're providing services for everybody, and that's the work that's happening. And on top, the work behind the scenes is happening. And I know we could probably talk about this for 2 more hours, but feel free. And if you guys have questions, more questions, give them in writing, and we can respond to them, and they can be public. I think that's things that we can respond to in public that we're able to share, or what we have answers for. Things that we're working on, you can have those, and you can share them publicly.
okay. Do you have time for one more?
Yes, for you, of course.
Okay, thank you. We've been talking about health center. In one of my constituents, they don't have a suitable health care or health center. And I know that we went to visit the health center. In the health center, it's part of the nurses' residence. So they cook meals in that residence, and it's not appropriate for many of our residents that lives in that small communities, and that's Wukwati, and they really do need, to improve the healthcare system, they really need a new health center, because their health center is attached to the government office, and the government office, they want to make some improvements. That is not a suitable place to put anybody in, even for overnight, it's a nurse's residence, so they cook, and some of the people are not used to the cooking, like, I mean, that smell, because, many of our indigenous are very simple. They don't use, like, a lot of spices in their food, and some of them are, it depends on the culture of the, nurses that are working there. So, because of that, a lot of our elders, what I notice is that they would rather be in Yellowknife, where the healthcare, they have better healthcare than their small communities. And I don't think that's their first choice, but sometimes they feel like they have no choice but to move to Yellowknife to be near the health facility. And that's what I heard from quite a few of our elders living in the small communities. And with that in mind too, with medevac planes, that will also help. How many medevac planes do we have there's 5 regions? So does each region have medevac plane? Because in one of the communities that I just talked about, we had an elder that waited for a medevac plane for 12 hours. So how many medevac planes do we have in the Northwest Territories? I know there's 5 regions. Thank you.
Thank you, Madam Chair. And just, so the air ambulance, the medevac, how we provide med response, and it's a territorial-wide system. It's not by region. So what we do have in the current contract, that we have increased the amount of planes that we have, I think, on standby for, but I can turn it over to Kirsten, because that falls under her area, and she will be able to give you a little bit more detail on that than I can.
Okay, thank you. Ms. Bird?
Sure. So I can start with answering your question about the Wequity Community Health Center. We've added that to our list of Northern and Arctic health assessment items, and so we don't yet know what the outcome of that assessment will be, but we certainly have acknowledged Wequity is one of the, one of the communities that is in need of something, and so we're cautiously optimistic that we're going to hear something soon. On the air ambulance, we have 2 bases in the territory. So there's a base in Yellowknife and a base in Inuvik. That's where the planes live all the time, and we dispatch out of there. I don't know anything about the circumstance you're speaking to, but I do know that the med response system, emerged triages, and so sometimes, depending on weather and depending on what else is happening in the territory, they might, put somebody who's in a higher need ahead of somebody else, and so there can sometimes be a long wait. Thank you.
Okay, thank you. And with that in mind, thank you, Minister. Improving the healthcare system in the small communities have been a long time coming, and I do appreciate. I think, this will really help many of our communities, especially the majority of them are the Indigenous. So with that in mind, I just want to say thank you for the public briefing. And so this ends our public briefing for improving the healthcare system in a small community, health reform. Thank you.